see. That would then mean Senator Cassidy is next.
Hey, y'all. Thank you for being here. It seems like we actually have two issues here. One is the ghost networking, which could be false advertising. And Ms. Myrick, your experience is so typical. Thank you for sharing it. It takes courage to do so, but just thank you for doing so. Second is access itself, because Ms. Myrick speaks of both, the false advertising and the lack of access. And I think you set the tone for the questions, if you will. Now, one thing that I'm struck by, Dr. Tressman, is when I would speak to, I'm a physician, so I'd speak to my colleagues back home who are in psychiatry, and they would say that Medicaid, Medicare rates were so poor that they got to pay the bills, et cetera, so they typically went to either private insurance or to cash pay. Then I've heard the reimbursement's been mentioned. But one thing that's not been mentioned in this is that traditional Medicare, which actually doesn't have a provider panel per se, that the access is equally poor for the traditional Medicare if you're speaking about something such as mental health providers. Is that a fair statement?
Yes, sir, it is.
I asked my staff, because we did a literature review beforehand, but they weren't quite sure if there had been kind of a crosstab, if you will, of access for Medicare patients, MA versus traditional Medicare. And I wouldn't be surprised if they're kind of roughly the same. Your thoughts on that?
I expect that they are, sir. The challenge in so many situations really is it's the administrative burden, it's the access, the management, and so I think that the MA versus Medicare plans, traditional, have some of the same challenges.
Now, theoretically, an MA plan, if they're challenged to increase their provider panel, they could actually pay better than Medicare rates in order to achieve that. If you will, the Medicare MA model, if done right, actually addresses the market issue, correct?
Absolutely true. And supply and demand is what this country was built on. But I don't think that that has applied appropriately to insurance plans. You know, I think that part of the challenge for us is to come up with an appropriate strategy where people, psychiatrists have told me repeatedly that, you know, I wish I could afford to be in the insurance plans, in Medicare, in MA, but it cost me more to deliver the
Oh, I get that. Believe me, you know, I hear that too. So I'm not disputing that. Dr. Resnick, as you kind of representing the entirety of healthcare, at least physicians of it, you could speak to this. There's also a little bit of a quandary that a doctor will see a Medicaid patient because her friend asked her if she will see the Medicaid patient. She doesn't really see Medicaid, but she's going to see this particular Medicaid patient because her friend asked her to. And so she remains on the Medicaid provider panel, but she doesn't really see it. And I think Ms. Gilberti said something along the lines of they're not seeing patients, so therefore they're not in network. Technically, that's not necessarily true if I will see 3 patients a month on Medicaid because my friend, who I've known since we were both in kindergarten together, calls me and says, please see this patient for me. Would you accept that as a valid kind of occasionally occurs at least?
Yeah, I think, thank you, Dr. Senator Cassidy. You know, I have such pride in my colleagues on the front line around the country who are doing their best every day to take care of their communities and the patients who present and the primary care colleagues who call to refer those patients. But as you have identified, payment rates are an issue. And, you know, we have, as we've talked about, 2 decades of stagnant rates in traditional Medicare. We have Medicare Advantage plans in some markets that are so consolidated that they're paying less than Medicare rates.
So let me ask you this. You know, my wife, who's a retired general surgeon, once said if they pay you below your cost, you can't make it up on volume.
That is true.
And so, but to that point, and knowing that there are people who, yes, I am on the provider panel because I still have some patients whom I see, and I will occasionally see a new patient under certain circumstances, it almost seems though that we have to have some sort of threshold to analyze this. Does a patient, yes, they're open for new patients, but how many new patients will they receive a year from this particular payment plan? Because I think we have to bring sophistication to this analysis as opposed to insurance plans are all bad, for example. Your thoughts on that?
Well, there are physicians on panels who have not seen any patients
I
for
get that.
years, and so that's fixable by the health plan. If it's a small number, then I think we need to turn to the physician. And there's a difference between being contracted, and we see this also with physicians at multiple locations, right, where they're contracted at 30 spots in case they go there, but they wouldn't want to be listed on the directory because they literally go cover for a colleague every couple of years. So I think this is where having a low burden way for physicians to have input and actually be able to tell the plans when and if they want to appear on those directories based on whether they're accepting new patients in that plan.
Well, so with my last, I'm over time, but in 5 more seconds, send me that low burden way. If AMA's got a way to do that we could somehow add sophistication to this analysis, we would like to hear from the frontline providers.
We will be convening stakeholders to help you to that point.
I appreciate that, and I yield.
Thank you, Dr. Cassidy. Senator Cortez Masto.